Hello, welcome to a brand new medical surgical lesson. My name is Jessie Wheatley and I'll be facilitating this lesson. Please be sure that you have your accompanying notes with you, your textbook ready, and something to write with so that you can follow along with this lesson. Thank you for listening in to this lesson. This lesson is on cardiac electrophysiology. This lesson focuses on the review of cardiac electrophysiology to include an understanding of the conduction system, lead systems, continuous ECG monitoring for the RN. By the end of this lesson, you should be able to understand lead systems, continuous ECG monitoring, ECG complexes, segments, and intervals, and the process involving the determination of the heart rate and ECG rhythm analysis. You should be able to provide a collaborative patient-centered care using the best practices of cardiac electrophysiology. You should have a basic understanding of cardiac electrophysiology, heart conduction system at the level of a medical surgical nurse. Now, let us begin by reviewing the cardiac conduction system. It all starts with specialized myocardial cells capable of regulating heart rate and rhythm through 4 different properties. I'm going to talk about all 4 properties here. The cardiac myocardial cells are capable of automaticity, which is a pacing function of the heart. They're capable of excitability, which is the ability of non-pacer cells to respond to electrical impulse. They are capable of conductivity, the ability to send an electrical stimulus from one cell membrane to another. And contractility, in response to the electrical stimulation, the cardiac muscle can shorten and contract and push blood through the ventricles. All 4 properties are responsible for the cardiac conduction system, the primary pacemaker being the SA node, which is the one that primary creates that automaticity, that in decreased blood flow, any cardiac muscle is capable of producing an electrical impulse if needed independently, creating a dysrhythmia. Think of conditions such as electrolyte imbalances. Think of things like hypoxia, drug toxicity, or cell death. Some cardiac muscles will independently create and produce an automatic impulse, but it will be registered as a dysrhythmia. Cardiac muscles, we talked about them being excitable. So the non-pacer function cells in it are able to respond to the electrical impulse that's coming to them and get excited to depolarize. Depolarization meaning that they're normally negatively charged cells, but they become positively charged once they have been excited. Conductivity deals with the ability to send an electrical stimulus from one cell membrane to another. Conductivity, depolarization results in a wave from cell to cell. This is what's reflected on the ECG waveforms called the P wave and the QRS complex. Contractility, I talked about that, the cardiac muscle's ability to contract and push blood through the heart. Let's now specifically review the specialized cells that are responsible for this conduction system. The cardiac conduction system, specialized cells are responsible for the generation and conduction of electrical impulses that cause atrial and ventricular depolarization. Specifically, we're talking about the SA node, as you can note here in this picture, and we're talking about the atrioventricular junctional area consisting of the AV node when we get ready to talk about it specifically. Let me show you another picture. There is another picture just for a different reference, the SA node, and we have the anterior, we have the AV junctional node area that we'll want to talk about. With the SA node, we want to point out that this is a heart's primary natural pacemaker. It can spontaneously and rhythmically generate 60 to 100 beats per minute. It is supplied by sympathetic and parasympathetic systems that detect whether to increase or decrease the heart rate. Impulse from the SA node will travel through the atrial muscle here and result in atrial depolarization. This on the EKG is going to be signaled by the P wave. The P wave. The atrial muscle contraction normally follows the conduction pathways. The slow and fast ones in the atrial muscle lead to the AV node. The atrioventricular junctional area consists of transitional cell zone, the AV node itself here, and the bundle of His. Let's go back to the other picture. So here we have the AV node, the transitional cell zone, and the His bundle, or the bundle of His. Transitional cells cause impulses to slow down or be delayed in the AV node before proceeding to the ventricles, allowing the atria to contract. It gives that atrial kick that helps cardiac output. And then the ventricles fill, which this delay is what is signaled as the PR segment on the EKG. This delay is what we see as the PR segment on the EKG. And then after that, we move to the bundle branch system. The AV node also is under sympathetic and parasympathetic control. The bundle of His connects to the distal part of the AV node into the interventricular septum. The Purkinje fibers make up the bundle. The Purkinje cells or the Purkinje fibers make up the bundle of His. Electrocardiography or an electrocardiogram then is a graphic representation or a picture of the cardiac electrical activity. So it's going to be a graphic representation or a picture of the cardiac electrical activity. So a lead provides one view of the heart's electrical activity. We can get multiple leads. Electrode placement for males and females is the same. Lead systems are made of positive pole and negative pole. So lead axis means an imaginary line between the positive and the negative. And the cardiac axis means a direction or the current flow in the heart's muscle itself. When we talk about lead systems, we include the standard 12-lead ECG system. That just means that we're looking at 12 different views of the heart. Remember, a lead represents one view of the heart. So we have the standard 12-lead ECG system. You can also have an 18-lead ECG, and there's even a newer ECG on the market that is an 80-lead ECG system. The standard 12-lead ECG system looks at 12 views of the heart, like I said, and you're going to, it has 6 limb leads, and it has 6 chest leads or precordial leads. You can look that. In your notes, I included a reference for you to know about how to place those leads. An 80-lead EKG system looks at 80 views, and instead of only 12 and gives a 360-degree view of the heart. Evaluation with this 80-lead system revealed a 15% increase in diagnosis of MIs over the 12-lead system. So it is evidence-based. It's what the newest thing is. On a unit that is a full disclosure with full disclosure monitors that they monitor patients there for continuous ECGs. You may you want to place them not on the limbs to avoid artifact. You want to place them on the trunk of the patient. ECG cables may be hardwired or they may be battery operated. As far as placing electrodes go, the placing of electrodes can be delegated to an unlicensed assistive personnel who has been trained to be able to place electrodes, but the actual monitoring of patient care is something that you cannot delegate. So remember that. You want to make sure that you're putting it on clean skin. You want to clip hairs or shave area if needed. You want to make sure the place is dry, free of lotion and tinctures, and is not irritated or scarred. Now, let us talk about time on an ECG strip. Time on an ECG strip is, first of all, ECG strips are going to be printed on a graph paper, like this one right here. Time is going to be measured on a horizontal axis. Each small block, itty bitty tiny little block there, equals 0.04 seconds. A large block this size equals 0.2 seconds. One large block is 0.2 seconds. So 5 of these equal a second. 15 of them equal 3 seconds. 30 of them equal 6 seconds. So that's how time is going to be measured on that graph paper. Now, let's talk about ECG complexes, segments, and intervals. Complexes, segments, and intervals. The first one I want to talk about is the P wave. The P wave is a deflection representing atrial depolarization. A deflection representing atrial depolarization. The shape can be positive, like in this nature. It can be negative, or it can be both positive and negative, which is called biphasic, depending on the lead you have selected to look at, the view you've selected to look at. If impulse is coming from SN node, the P wave maintains a consistent shape in the given lead. So it looks the same in whatever lead you're looking at. If impulse has an ectopic or different focus, this is noted on the P wave as it changes in the same lead. So you want to look, when you're looking at the P wave, you want to look at the P wave in the same lead to see if the impulse is being generated by the SN node. Now, I want to talk about the QRS complex. The QRS complex represents ventricular depolarization. It represents ventricular depolarization. We said that P wave represents atrial depolarization. This one represents ventricular depolarization. The shape depends on the lead selected as well. Okay, so the Q wave represents the first negative deflection. It may not be present in all leads. The Q wave is abnormally present in a lead. When abnormally present in a lead, it represents myocardial necrosis. The R wave is the first positive deflection. It can be small or large or absent depending on the lead you're looking at as well. The S wave is a negative deflection, and it comes after the R wave, and it also may not be present in all the leads you're looking at. The next complex I want to talk about is the T wave. The T wave follows the ST segment here. It represents ventricular repolarization. It usually is positive and rounded and a little asymmetrical. If an ectopic stimulus excites the ventricles during this segment, it may be called an R on T phenomena. This can cause ventricular irritability. It can cause a lethal dysrhythmia. It can cause cardiac arrest. T waves can be tall, they can be inverted, they can be flat, and they change in MIs, in potassium or calcium imbalances with meds or ANS effects. Your textbook talks about sometimes what's possible called a U wave. A U wave is when it follows a T wave resulting from slow repolarization of the Purkinje fibers. Some polarity as T wave, but generally it's common in lead V3 and not seen in all leads. An abnormal U wave signals hypokalemia or an electrolyte imbalance and should not be mistaken for a P wave. You want to notify a doctor, you want to check potassium levels, and in your textbook on page 716 or thereabout is a picture that I have referenced in your notes. Now I want to talk about the PR segment and the ST segment. The PR segment is an isoelectric line from ending of a P wave right here to the beginning of a QRS complex right there. Remember the delayed electrical impulse through the AV node, then through the ventricular conduction to the Purkinje fibers? There is your PR segment. The ST segment is an isoelectric line representing ventricular repolarization. It comes from the J point where the QRS complex ends and the ST segment begins. It's called the J point to the beginning of the T wave. The length of an ST segment changes with heart rate, with meds, with electrolyte imbalances, and other things like that. The ST segment is not normally elevated greater than 1 millimeter or depressed greater than 0.5 millimeters from the isoelectric line. Elevations and depressions signal myocardial injury, ischemia, infarction, or conduction abnormalities or medication effect. Let's talk about the PR interval here. The PR interval is from the beginning of a P wave to the end of the PR segment. It represents the time required for atrial depolarization. Normally, it is 0.12 to 0.20 seconds. The QRS duration represents the time required for depolarization of both ventricles, and it normally should take 0.04 to 0.10 seconds. The QT interval represents the ventricular repolarization and depolarization. From beginning of the QRS complex here to the end of the T wave is what is referred to as the QT interval. It varies with age, with gender, with heart rate, and with medications and electrolyte imbalances also affect it. Your textbook talks about artifact on an ECG tracing. An artifact is just interference that can come from bedding or brushing teeth or anything like that. Do not rely on an ECG tracing. You need to make sure that you're assessing your patient, because sometimes artifacts can look like some lethal dysrhythmias. You want to make sure that you're getting your eyes on that patient. Now let's talk about how the heart rate is going to be determined on an ECG strip. 3 methods can be used. The first method is the 6-second strip method. The second method is the big block method. And the third method is going to be the memory method. The 6-second strip method is estimated by counting the number of QRS complexes, in 6 seconds times 10. That's how you get the heart rate for the full minute. This is a quick method. It's the least accurate, but it's a method of choice for irregular heart rhythms. The big block method is what's illustrated here. The big block method comes from counting the number of big blocks. Remember those big blocks we talked about? Between the same points in any 2 successive QRS complexes. Okay, so you may go from R wave to R wave. You divide that number you find into 300. So we have 3 boxes here. So we're going to take the 300, divide the 3 boxes, and we are determining that there's 100 beats per minute happening. If the little boxes are left over, you can count each little box to represent 0.2 seconds. We're talking about baby little boxes here. Then divide that into the 300 as well. The last method is the memory method, and in the memory method it pretty much relies on you memorizing a sequence that is going to give you the answer of the big block method. So it's the big block method with a memorized math. So you're going to memorize the sequence 300, 150, 100, 75, 60, 50, 43, 37, 33, and 30. You're going to find the QRS complex that's falling on the dark line representing the 0.2 seconds or a big block, and counting backwards to the next QRS complex. Each dark line is a memorized number. This is the method commonly used in hospitals for calculating a regular rhythm. So commercially prepared ECG rulers are available for regular rhythms. Also remember that most monitors will display the heart rate for you, but the RN must confirm by assessing the patient's heart rate. Let's now briefly talk about how you are going to analyze an EKG tracing. You're going to take a strip and you're going to look at it, and using the 5-step method that facilitates what's going on. You may also use calipers to make sure that you are doing this correctly. The first thing you want to do when you're looking at an EKG strip is you need to determine their heart rate. Okay, you want to look at the heart rate. Normally it should be 60 to 100 beats. Bradycardia is when there is less than 60 beats per minute. It says 6, but it's really less than 60 beats per minute. Let's fix that because that's going to drive me crazy. So it should be 60 beats per minute. Tachycardia is going to be more than 100 beats per minute. The next thing you want to do is you want to determine the rhythm. the heart rhythm. Is it regular or irregular? The textbook shows you how to use calipers to be able to tell that. The next thing you want to do is you want to analyze the P wave. You want to see if the P wave is there. Is it present? Is it occurring regularly? Is there one P wave for each QRS complex? Is it smooth and is it round? Is it upright? Is it not inverted? Okay, the next thing you want to do is you want to look at the PR interval. You should check that it's between 0.12 and to 0.20 seconds like we talked about, and you want to note any variations in that. PR interval is constant across the strip. The last thing finally is you want to measure the QRS duration. The duration should be between 0.04 seconds to 0.10 seconds. And you want to see if there's any that are less than or greater than 0.12 seconds, and our QRS complex is similar in appearance across the ECG strip. So using those 5 steps, you will be able to determine if there's a cardiac what the cardiac rhythm is, and you'll be able to tell whether it is normal or not. Let's look at a normal sinus rhythm here as an example. So we're going to look at normal sinus rhythm. Can you tell the heart rate? Are you going to be able to use one of the methods that we talked about to determine the heart rate? And another thing you can do is you want to look and you can see that the atrial ventricular rhythm is essentially regular, and there's one P wave following each QRS complex, and all the P waves are consistent shape. The PR interval is constant and within range, and the QRS complex is constant and also within range. Thank you for listening to this lesson. I hope you have reviewed cardiac electrophysiology. I also hope that you have now gained a better understanding of lead systems, continuous ECG monitoring, ECG complexes and segments and intervals, and you know how to determine the heart rate and how an ECG rhythm analysis is conducted. For questions about this lesson or any of the corresponding notes, please feel free to email me at the address I've provided. Thank you and have a wonderful day.